Hello everyone and welcome to this live in a box surgery session. I am Vlad Mihalcea and it is my great honor to introduce to you Dr. Octav Ginghina and his team. Dr. Octav Ginghina is a senior specialist at Monza Hospital and a lecturer at Carol Davila University of Medicine and Pharmacy. He started his career as a resident at Sfântul Ioan Emergency Hospital. His passion for oncologic surgery determined him to continue his studies in Belgium where he super specialized in hepatic and pancreatic surgery. Later, he came back in Bucharest, where he currently unfolds a wide activity in hepatobiliary, pancreatic, endocrine, and breast oncologic surgery. He is a member of the audit committee of the European Society of Hepatobiliary and Pancreatic Surgery and a member of the Belgian Royal Society of Surgery. Dr. Ginghina and his team will show us the minimally invasive techniques for hepatic resections and then introduce us to a day in the life of a HPB resident. With no further ado, I gladly invite you to enjoy an incredible session led by an experienced doctor in the field. Doctor, you have the scene.
Thank you. First of all, I want to thank the organizers for inviting me here. It's an honor to present in front of you all. It's a presentation, but it's more of a story of surgical oncology department that started from mostly from nothing and grows to be today active, and I would like to hope of it, think of it as successful HPB department. HPB stands for hepatobiliary and pancreatic surgery. As you see in my title, this is a story from the learning curve, from two aspects of it. First of all, we are still on the learning curve because going to laparoscopic surgery was not very easy for us, and I will explain a little bit later why. And in the case of hepatic surgery, I mean. And second of all, I think that we are all on the learning curve, and I hope we are all the time on the learning curve till the day we finished our careers or we die, because what will be medicine without learning? As much as HPB surgery, as much as liver surgery, it is well known that HPB surgeons started from doing a lot of big surgeries and doing them in the open approach in the beginning. So so we did the same thing, because we started mostly from zero, and choosing the right patient was the most difficult part of it. Choosing the right person, and that meant choosing the right patient with analyzing the patient history and comorbidities, the lesion location, and the lesion site. Location is practically most of it in liver surgery. Liver is a difficult organ to approach on the surgical part. It has a very complex vascular structure. I will very shortly go over it again. And of course, the advantages of laparoscopic surgery are very well known. It's the difference between a huge incision and very small incisions with decreased length of hospitalization, low postoperative pain, lower complications, and of course the most important thing is the fast recovery. Patient is going very quickly home, he's going back to his life very quickly, and that is practically the biggest advantage. And of course, the lesser the trauma, the lesser the immunological setback that comes with any surgery. So on the oncological side of you, it might be one of the reasons for a better oncological aspect on the long term. And of course, in HPB surgery, things took a little bit of time, but we have now the consensus that says that laparoscopic liver resections are as safe as open liver resections in expert hands and in departments that have a lot of experience. I don't think of us this way. I think of us still on the learning curve, but we are very enthusiastic about this and going further in this direction. A very short anatomical reminder of the liver anatomy. As you know it, we define the liver with its segments. Segments are based on the Glisonian pedicles. So this means the portal vein, the hepatic artery, and the bile ducts. So it will be here that will be the falciform ligament, and we'll define the right liver and the left liver based on the divisions of the Glisonian pedicle. And of course, the liver is the only organ who has a double venous vascularization, as you know, that the veins that goes to the suprahepatic veins, and defining this way a very difficult and complex vascular structure of the organ itself. So we have a few type of resections. First of all, is atypical resection, where we just take out a tumor that it's very, quite easy to diagnose, and it's probably one of the most friendly and easy operations in liver surgery. And of course, we have segmentectomies, which is resection of one segment. But things were a little bit not so clear till 20 years ago, when the Brisbane Convention made a clear definition what are the sections. So we define the sections as, on the right side of the liver, we have segment 6 and 7, which stays posterior to segment 5 and 8. So we have the right anterior and posterior sectionectomies. And on the left side, we have segment 4 and segment 2-3, which they sit medial and lateral. So we have left medial, and left lateral sectionectomies. As this might sound a little bit complex on the first side, when you see the liver and when you do liver operations, then you see that it's very logical. We don't use Roman numbers; we use Arabic numbers. So everybody should understand them everywhere in the world. When you see a protocol, an operation protocol for liver surgery, anybody should understand it very, very quickly. This is very important for us because HPB surgery is also a community surgery. We tend to communicate a lot, I think more than in other specialities. And so everybody can understand when someone is describing an operation, anybody should understand it anywhere in the world. A little bit about our story. We started HPB surgery in 2013. We returned from training abroad. But what I would like to say is that we never thought about doing so much HPB surgery in the beginning. We just had one frustration. And our frustration was that we had colorectal cancer. We did a lot of colorectal cancer at the time, and we couldn't do the 4th stage colorectal cancer with liver metastasis. So that was the problem, and that's why we start thinking about liver surgery. We never thought about developing an HPB department. We never thought about all this. It just opened this extraordinary world to us, but we just left and go abroad to learn HPB surgery in order to operate the patients with colorectal cancer and to offer them a resection for the liver metastasis. So that's where we started from, and then. When it came back, we were sustained by a whole team. This is a very team effort. Without a team, you have no chance of doing this kind of surgery. And afterwards, of course, complex liver surgery followed, hepatocarcinoma surgery, cholangiocarcinoma surgery, and of course, pancreatic surgery. In 2015, we did the first laparoscopic. As criteria for choosing the cases, as I've said before, the key of this surgery is choosing the right case. And choosing the right case to start was very difficult for us in the beginning because, as I said before, we had no history in HPB surgery. So of course, we had as relative contraindications. We didn't start with very difficult cases near important vascular structures, and of course, additional pathology was also a case. And absolute contraindications, of course, that any case that you are not sure that you can offer the patient an oncological safe resection, an oncological complete resection, you should not go for laparoscopic surgery, but just do the operation that will give the patient the best oncological result. And of course, anesthesia contraindications, as you know, and I'm not sure how much you know, but when you become residents and surgeons, you know that anesthesia and surgery is a little bit like a marriage without the advantages of the marriage, just the disadvantages of the marriage. So as our history goes, of course, we did a lot of anatomical resections, so going by the pedicles and taking everything on the side, and then we did also a lot of a lot of laparoscopic liver dissections in our last year. As you can see here, our last year, we consider it till March 2020, because afterwards, you know, it started the pandemic and everything. So we did 93 cases. One of the biggest things that stopped us in the beginning in developing a big experience in laparoscopic surgery was that we were not able to do ultrasound, intraoperative ultrasound in laparoscopy because of technical reasons. We didn't have an ultrasound laparoscopy. So in all of our patients, we did operative ultrasounds in the beginning, and we couldn't do it in laparoscopic surgery. So that's why we started a little bit later. And it's still a thing, because we do most of our resections, we do them ultrasound guided. And of course, in the beginning, this was a very, very big stop and setback, and in time we resolved it. Okay, so I'll present for you very shortly 2 cases. First case is a patient with a cirrhotic liver and portal hypertension who developed a tumor in segment 4-8, but it's mostly segment 4. And I'll start the video. I hope you can see the video. So when you see the cirrhotic liver, it's most of the time, most of the surgeons will be very, very careful about cirrhotic livers, and they will be. But the liver surgeon is not always so scared of the cirrhotic liver. One of the reasons is that fibrosis that comes with cirrhosis can sometimes help you during the operation, in the meaning that the liver has less vascularity. You can see here the tumor. It's very easy to see it. It happens that sometimes cirrhotic liver will bleed less, and it will be even an easier case. As a concept, it's mostly of the cirrhotic liver on alcohol use are more difficult to operate than cirrhotic liver on hepatitis, but it's not a rule. As you see here, we divided the falciform ligament in order to have a better view of the tumor and of the segment 4. We went towards the area nuda, towards the inferior vena cava, but we didn't dissect it completely because there was no need. We performed an ultrasound. We determined the margins of the future resection. What is very important, and I have to say it once more. We are very, very much concerned about how much can we take out of the liver. In this case, it's not a problem. We're not taking so much. This tumor is not so big, but the future liver remnant is the key of liver surgery most of the time. How much liver can you take out? So the liver that stays will still have a good function, and you will not get a liver insufficiency. Liver insufficiency is liver failure. Postoperative liver failure is the nightmare of the liver surgeon, because you cannot do anything most of the times. You can just put it on the transplant list, on the urgent transplant list, and as you probably know, this is very, very difficult once more in Romania. And so looking at the patient preoperatively, choosing the right patient is very, very, very important. And you have to think also about the liver function. So it's not only volume. You don't only calculate on volumes, but you also look at the liver function to see if the liver can stand the function afterwards. I think it was not presented in the images a little bit further, but always we made secure the liver hilum in case of a huge bleeding that we should do Pringle maneuver in order to control the bleeding that comes from the Glisonian pedicles, and of course stop the bleeding and control it in safe mode. So everything should be very, very, very careful. We proceed very carefully. If you see here, we use a lot of suction, but we use a lot of surgical mesh. And the reason we use surgical mesh is on laparoscopic surgery. The mesh will give you a more clear view. It's white. It carries more light, and using just suction sometimes is very difficult. Also, you have to know for liver surgery, you need a special insufflator, because you will do a lot of suction, so you have to have more insufflation than in normal laparoscopic surgery. If you don't have it in the beginning, you can still begin doing liver surgery. This is how we began doing liver surgery. We began doing liver surgery in low-cost conditions, I have to say it. My residents know it. I always say that a good surgeon should be an expensive surgeon, because if you have to use all the time the best thing that you have for your patients, but we started in quite difficult conditions, and the operation took a lot of time because there was a lot of smoke, and we have to take it out and then suction, and this takes a lot of time. As you see here, we proceed in the liver parenchyma. The thing is, sometimes you have some bleedings, but you should not just go step by step. Liver surgery is not so difficult. I've chosen this case especially to encourage people to come and to join liver surgery programs, because this is a friendly case, and you should proceed, of course, with care, because you know, we know from the preoperative time where are the big vessels. You have every case, you have to go and study it with your radiologist. You have to study it with your radiologist. Okay, you can study it yourself if you're a very good radiologist, but most of the time you should study it with your radiologist and see which branches come near your tumor. If you do an atypical resection, which looks very friendly on the video, you have to study it and know exactly where your branches come. The branches from the Glisonian, so from the portal vein, from the artery, and also the branches from the hepatic veins, which is, of course, sometimes the biggest problem, because they have a much more friable wall. So you have to know where your branches are in order to have hemostasis. And you see here this. We do a lot of hemostasis after the operation, even if here there was no major branches in this area, and we still do a lot of hemostasis. So there are two things you have to do to be sure of at the end of every operation. So one is hemostasis, and the other one is biliostasis. So stop any leak from the bile ducts, from the small bile ducts. Here is the tumor. We put it in a contention bag. If I would knew that we would present this movie, we would use a better contention bag, but this is a contention bag made from a glove. So you have to use what you have at hand. And of course, recheck hemostasis. Placing drains, to drain or not to drain. You see in the literature, sometimes there are a lot of people who are talking about no drain surgery. You see, these voices are very, you hear these voices much less in HPB surgery than in other surgeries. A drain will do no harm. Keeping a drain, and you see here we also place hemostatic Surgicel mesh on the surface. So I'm coming back to the drain. So putting a drain will not harm the patient. There will be no problem. It will not stop his postoperative recovery. And you have an eye in the patient abdomen for more than 24, 48 hours after the operation, and you can be very, very safe in case you need to do you have to do a redo or something about this patient. About hemostatic agents like Surgicel, like Tahosil, and a lot of things you have to know. There are no studies. There are no studies that prove that they are useful. The only use that they really have is for the surgeon good night's sleep. So the surgeons put this hemostatic agent and he thinks everything is better, so he will sleep better, but there is nothing proved in the studies that this will really help. You have to have a good surgical hemostasis in order to be safe. The hemostatic agents will not help. And of course, I'm coming back to the drains, to the drain discussion. You should know that drain, there was a study published in HPB 2 years ago about no drain in pancreatic surgeon, and the study was stopped after 3 months because of complications in patient without the drains. So the drain is very, very useful. This is postoperative aspect of this patient. As you can see, there are very small incisions, and the patient was 48 hours afterwards went home. He wanted to go home the next postoperative day, but we stopped him. We stopped him because we are more paranoid than our patients. So another video. So this is a patient with a metastatic lesion in segment 2-3. So we're going. So this is the falciform ligament. This is segment 2-3. So we're going for a left lateral sectionectomy. The patient had a gastric neuroendocrine tumor that was operated before, and he was referred to us in order to do a left lateral sectionectomy of segment 2-3 for a neuroendocrine metastasis. This is mobilization of the left liver. This is a very important point during the operation because I would like to. Okay. You see here, this is segment 1, so the caudate lobe, and here we make the freedom from the left triangular ligament, and here it is the vena cava below the ligament of Vacarasu. So this is a very important point because here you can make a lesion of the vena cava. We did this. This is why I'm telling you this. We did in our first segment 2 and 3 resection laparoscopically. We did here a small lesion of the vena cava. Happily, it was solved laparoscopically. We didn't have to convert it. So you see here, this is segment 2 and 3 completely freed. This is area nuda, and here you'll see immediately the inferior vena cava. So isolation and dissection of the hepatic vascularization from the hepatic veins in order to isolate both sides. And this is the left side of the liver hilum. Here is the falciform ligament, and here you'll immediately see that here comes the left branches from the liver hilum of the Glisonian pedicle. We mobilize the liver on the posterior side, and then we mobilize it from the anterior side. And afterwards, we will go to the parenchymal resection. As you can see, this is very step by step. I've said it before. It's always step by step. Don't hurry. Go step by step. You see here. This is you can already see the branches for segment 2 and 3. So from the left portal and left portal and left artery. And you see the branches for segment 2 and 3. They were taken here with surgical clips, and you see here it's a branch from the hepatic veins that comes down here, and you can see here compared to the Glisonian pedicle, you see here that the veins from the hepatic veins have much thinner wall, and they are much easier to make a lesion of them. Bleeding from the hepatic veins is also always a nightmare, and especially from the middle hepatic vein is the biggest nightmare. And here is here we take the left hepatic vein. This is dissection plan here, and this is taking of the left hepatic vein with a vascular stepper, and we put another vascular stepper, and that will finish the segment 2 and 3 resection, which is practically the most friendly and easy to do resection, typical anatomical guided resection of the liver. And this is postoperative aspect. As you can see here, this was a much bigger tumor, so we had to do an incision like mirror McBurney on the left. We did it on the left side. You can do a Phalansteal. If it's a lady, it's better to do a Phalansteal incision. So this means a hypogastric here incision in order to have a better aspect of it. If you expect a very difficult case, what you can also do is to make a small incision here, or if it's a man, wherever it's more comfortable for you, you make an incision and you cut the skin, you cut the muscles, you leave only the peritoneum intact. You start the operation laparoscopically, and if you have a big bleeding or you have a big problem, then you just take your hand, put it inside, and stop the bleeding. Also, you have to remember in liver surgery, what's also very important is that we do all these surgeries with low venous pressure. Doing liver surgery in order to lose less blood, in order to have to minimize the blood loss, you have to do this operation with low central venous pressure, and your anesthetist has to know this. Your anesthetist has to know this. If you look at these images, you see here that the veins are not. You have to see that the veins are not fully. If the vein is fully blocked, and so one liver surgeon says stop the operation and wait for the pressure to lower it itself in order to continue the operation. Otherwise, I'm trying to show the vein. Yeah, so you see the vein is very easy to compress. The vein, there is very, very low venous pressure in all these surgeries. So pneumoperitoneum itself, so the gas that sits in the peritoneum in laparoscopic surgery, will make the bleeding a little bit less. So you have to know when you have to open a patient, when you have a big bleeding and you have to open the patient during the procedure, you will be having a lot more blood loss at the moment of opening the patient. That's why if you have a place where you can put your hands in at the time of the surgery and stop the bleeding till you make a big incision and open the patient, that will always be helpful. Take it or leave it, there are a lot of technical details. I'm not gonna, this is my presentation. I would like to mention it. It's a lot of teamwork, but laparoscopically, minimum invasive surgery is not the goal. Our goal is to help the patient, and our goal is to offer the patient a good oncological result and to take out the cancer with an R0 result, so means no residual tumor. So that is the goal of this surgery, and laparoscopy itself is not the goal. Laparoscopy is just a way. Why I'm saying this? Because sometimes in our, and I've seen this before, in our search of doing more and more minimally invasive surgery, we sometimes tend to make compromise with this, and it's difficult to not to make this compromise. But take it or leave it, laparoscopy is not the goal. Taking your patient home, that's the goal. As one professor have said, difficult cases, difficult decisions, take the decision that will take your patient home. I would like to extend this great thanks, because managing my team and learning about team, I haven't learned it in surgery. I have learned it on the rugby field with my colleagues from GFP Rugby Club, and I would like to extend my thanks to them. And I would like to extend my invitation for you as already as students. You can always join our research plans, our research programs, and of course join the EHPBA, the European Association of Hepatic and Biliary Surgery Association. We have a special trainee section. We have a student section. There are a lot of programs and everything. And of course, join our future congress in EHPBA that should have been in Australia, but of course it will be unfortunately online. Thank you again.
We thank you, doctor, for this amazing presentation. And now we have a few questions. For an hepatocellular carcinoma on a cirrhotic liver, can an ALPPS procedure be used to prevent hepatic failure?
It's true that liver partition, so ALPS, can help. The reason that people do portal vein embolization or ALPS, liver partition, is to make to ensure that the liver remnant is bigger. It gives time for the liver to start regeneration even before surgery, and this is the reason. So yes, it can prevent liver failure, but how is this happening? So you're doing first the procedure, the ALPS procedure, so the liver partition. You divide the liver in two. You make a portal vein embolization on one side, and then you will the other side will start regeneration in order to have more liver function and of course to prevent liver failure. After 1 month, or it depends on the surgical team standard protocol, there will be a re-evaluation. ALPS does not guarantee that you will avoid liver failure, but gives a very, very good prognosis that you will avoid liver failure. So yes, ALPS is a very, very good option. We have some experience with portal vein embolization on our team personally, we are a little bit, how will I say, cautious about doing ALPS procedures. But of course, there is a lot of experience today with ALPS, and it's a very good question in difficult patients.
Thank you, doctor. On to the next one. What tests are done to check liver function before we start the surgery? Only lab tests?
No. We do lab tests, and of course, you know that we have some scores, and one is in case of cirrhosis, and in case of liver failure, we have the child classification, child A, B, C, cirrhosis, that's one of the things. We have the MELD classification, that's also based on the lab results. Second, we do imaging, so this is CT, MRI, which will give the radiologist the chance of calculating the liver volume, and we have two variables: the lab results that give you the answer to the liver function, and the imaging that gives you the answer about the volume of the liver that will be the future liver remnant. But except this, there are other tests, and one is ICG clearance of the liver, and the other one is membrofilin scan, scintigraphy, which gives you a direct image of the liver function, of the liver capacity of clearance. So that will give you a complete image, because okay, we are going to leave, let's say 40% of the liver in case of a cirrhotic person. According to literature, that is the maximum we can go for a cirrhotic liver, take out 60%, leave 40%. But are we sure that the function, are we sure that the cells, the hepatocytes that will stay are functioning enough in that 40%? In order to do this, it's better to have an ICG test or a scintigraphy with membrofilin, which is not always easy to do. But of course, volume and lab tests are the king of the thing.
Okay, thank you very much. And the last one would be, how is the blood flow to the vital liver parenchyma not compromised during the procedure?
We are just taking out the vessels that go to the diseased part. As you saw in the second video, we are taking out for example, the left hepatic vein, which takes the blood out of the segment 2 and 3, and of course we take out only the only the branches that go to segment 2 and 3 from the portal vein and from the artery. When you do big liver surgery, and you do left hepatectomy or right hepatectomies, of course there is always a little bit of liver parenchyma that will be, let's say, in the middle, like the people in the border. And there will be, of course, but most of the time that the liver has such a complex vascular network that the vessels from the other side will take over on the border side from what's left from the other side. But most of it, that's the key of liver surgery, is to taking out just the blood vessels that will vascularize only the pathological part and not damage the ones that for the liver that stay. One more thing. Sometimes, for example, if you have a segment 7 tumor and that sits on the right hepatic vein, but the right hepatic vein also drains segment 6, segment 5, segment 8. So you have two options. One, to do a right hepatectomy, which is huge operation. You take out a lot of liver parenchyma, and you have to think, because these patients, most of them, they will also go to do chemotherapy, so they need a lot of liver in order to metabolize chemotherapy. So every liver cell is valuable to them. So it's better to do a liver segment 7 resection, and you can do a reconstruction of the right hepatic vein, which is very difficult, but it's possible. So so it's very important, and that's why I think it's a very good question. It's very important always to make the effort in order to preserve the vascular site of for the future liver remnant.
Thank you. Some more questions came. Which criteria are important to choose minimally invasive surgery over open surgery?
Well, very good question. As I said before in my presentation, this is something we can talk for a night about this, I have to say. it's very complex. It depends where you are. It depends where you practice. It depends of your backup, because I've said this is a teamwork. Yes, we have started with very, very simple cases in doing laparoscopic surgery in the beginning, and we go to very slowly to more complex cases. But you have to understand that we've started mostly from zero. So in the beginning of our surgery, there were a little bit of a romantic times, I have to say. A left hepatectomy would take in our department 9 hours, and it takes today 2 hours or 2.5 hours. So, but we had in the beginning no backup. You see, if you go to a HPB department that already exists, that you have experts there, you can start doing laparoscopic surgery. For example, like I've presented a segment 2 and 3 resection. It's a very standard operation, and you'll be able to do it in the beginning. There's no problem if you have an expert behind you. But in the beginning, we had no expert behind me. We also stopped operation and called in Belgium to ask for advice in the beginning. So we did everything, and that's why we started very, very, very slowly. And choosing the right cases, it's very difficult. I've presented the slide with contraindications. In the beginning, for example, we didn't approach even gallbladder cancer or carcinoma. We never did, or cholangiocarcinoma. We never did it laparoscopically, because the oncological resection safety was not there for us. We were not sure in the beginning. We didn't have so much experience to say, okay, we can do a good oncological resection. So as I've said in my presentation, laparoscopy is not the goal. A good oncological resection is the goal. So when you're sure that you have did your time and you can now safely do this laparoscopically, then of course it's very, very good. So you should do it step by step.
Thank you for the advice, and we have some more questions. What are the complications of these kind of operations?
Oh, I can write a book about complications, because surgery comes with complications. I have to say, and I think my residents agree, and you see the next presentation, liver surgery has not so many complications as pancreatic surgery. I'm here today to encourage you people to join HPP programs. I know HPP programs are not so attractive as other programs in surgery. I know we are considered somewhere about very difficult surgery, very long hours, which is well, true. But liver surgery comes with some clear complications, and one is bleeding. Yeah, so the first 24, 48 hours after the operation, you have to have very good eyes on the operation. We don't do this in day surgery, never. We keep the patients at least 48 hours after the operation. Maybe one day we'll keep them only 24 hours. I don't know, but still we're a little bit paranoid. So bleeding is the first complication, and can be very, very dreadful. Second of all is bile leak. Bile leaks from the transaction from the liver parenchyma are sometimes very, very difficult to manage. Why? One of the reasons is because you have a bile leak. The bile duct it's not obstructed, and you have to find the bile leak, and you have to stop it one way or the other. And just taking out the pressure from the bile duct, of course, you can do this, but will not help so much like in, for example, bile duct lesions in the bile duct. So bile duct in the parenchyma are always more difficult to manage. Luckily enough for the liver surgeon, they are not so big most of the times. So this is another complications. As for complications in surgery, anything can happen anytime, of course. But these are the main complications that come. And of course, liver failure. Liver failure is a nightmare. Liver failure is a nightmare of the liver surgeon, and it's very difficult to use it. And sometimes, of course, if your patient has a liver failure, you will lose a patient. What I have to say, if you calculate your future liver remnant very well preoperatively, sometimes you have liver failure from surgery itself. So surgery itself is a trauma, of course. Yeah, we take a patient, we cut it in half, we take something out. That's trauma, no doubt. So even from surgery, you will have liver failure because the liver sometimes stops, especially in cirrhotic patients. So I can tell you patients where we didn't do a resection, we just do an ablation, RFA or a radiofrequency ablation or microwave ablation. So we just ablate the tumor, we didn't resect it, and the patient still got liver failure after it because of the shock. But that's liver failure that will be reversed, and that's a liver failure that you will solve till the end. However, liver failure from not enough liver parenchyma, that's a nightmare. Yeah.
Thank you once again. And I've got another one. Is CEUS also used for the patients with metastasis?
Sorry, what's CEUS?
CS. I don't know exactly. I've got it like this.
You mean SILS, like single incision laparoscopic surgery? SILS?
No, it's CEUS. I don't know exactly
what
what this is. Okay.
I don't know everything. We're on a learning curve. I've told you I don't know everything.
And I think this is the last one. What does the anesthesiologist do to maintain low venous pressure during the procedure?
To the patient or to the surgeon? Because to the surgeon, he's terrorizing the surgeon. You have to know this, because you have to understand that yes, well, this is what the difference between a great anesthetist and between an anesthetist, and this is crucial. You have to dehydrate the patient first of all. So before surgery, you have it's so different, huh? In pancreatic surgery, we will make the patients drink so much before surgery, so they have carb loading. We make them drink juices and everything. And in liver surgery, we don't let them drink anything from 8 o'clock. And you have to the night before, and you have to know the patients, because the patient, when they hear they can't drink anything, they start being thirsty. I understand this. I would be thirsty if you tell me now that I cannot drink anything, and it's very difficult. So that's one of the things. The other thing, he will maintain the perfusion of this patient very, very low. So what does this mean? This means that you have a patient that has a good cardiac output, otherwise you have cardiac problems. You have a good kidney function, otherwise you will have kidney problems. Yeah. So how this operation goes, you start the operation, you start doing the liver resection, and then the moment you finish the liver resection, you let know the anesthetist, we have done with the liver resection, start perfusion, start filling the patient with liquids, because this is very, very important. So that's why the anesthetist is very, very, very important. Otherwise, you will have a lot of blood loss. Another thing I would like to say, just to make a picture of how everything is complex and difficult. Sometimes you need to operate up in the liver next to the diaphragm. It's very difficult if you put the patient in anti-Trendelenburg position. So you put the patient with the head up. You have to know that sometimes when we have very, very small venous pressure, the pressure in the veins will be lower than atmospheric pressure, and you have to, again, if the patient sits with the head up, then you can have embolic gaseous embolism from the gas. So the patient should always sit horizontally in liver surgery. So it's all these things. You cannot manage all these things all by yourself, as a surgeon. The anesthetist has to be there, has to be all the time there. The patient has to have warm sheets. The patient has to have a low central venous pressure in order to have less blood loss. Yeah.
Okay, thank you. And I'm going back to the question before, because I think the participant meant contrast enhanced ultrasound.
Okay, ultrasound. Yeah, sorry, contrast enhanced ultrasound. Yeah, we use very rarely contrast enhanced ultrasound. Normal ultrasound is good enough. Fortunately enough, liver metastases have a much easier ultrasound image, and you can see when you put your cautery, when you put electric on the liver surface, it would also it will also leave a shadow, and that will be your landmark to start your resection, and you can see the difference from the metastasis to the resection margin. Of course, contrast enhanced ultrasound gives you more information, and mostly in cholangiocarcinoma or in primary and intrahepatic cholangiocarcinoma, it's much more useful in order to see exactly the anatomy of the liver. Personally, in our experience, we don't use control enhanced in metastatic liver lesions.
Okay, thank you. And the last one comes from me. Can we improve the resectability of segments 7, 8, and 4A through the laparoscopic approach?
Can we improve the
resectability?
It's a very good question. It's a very difficult question. Yes, well, segment 7 and 8, it's the challenge for the liver surgeon. It has segment 8 has the middle, and 4A has the middle hepatic vein, which is the nightmare of the liver surgeon. And of course, we have everybody who does liver surgery has at least once saw major bleeding from the middle hepatic. It is true that there are experience, but this is not our experience. There are teams that are much more experienced than us, and they have a lot of experience with transthoracic or transdiaphragmatic approach of segment 7 and 8. And coming from upstairs, coming from that side, you will have a much better view in the liver. However, there were reports in the literature of cases with major bleeding during this approach. So we are speaking up here about, of course, saving as much liver as possible and doing oncological segment 7, 8, and 4A. I think that the future stays here. The future stays here, and that's laparoscopic. And I also think robotic surgery will be a big plus, because in robotic surgery you can also have a better view from up till down. And I think the future is there, because that's the best way to save do a segment 7 or segment 8 or 4A resection. But what is my fear, and I have to admit it, is what you do if you have a vascular lesion. How quick can you control it laparoscopically or robotically? So I think that when you start, thank you.
Thank you very much, doctor. This was the doctor's presentation. Now his team will present us a day in the life of an HPB surgeon.
I would also like to say something. I'm very curious about this presentation, because they didn't want me to see this presentation. So I'm more curious than the rest of our colleagues, I think, because okay, thank you.
Thank you very much again, and please, Dr. If you can start your presentation.
Yes, here. So it's a challenge to present after Dr. Ginghina, but I will try to make you take a glimpse in the resident life, a resident in a HPB team. So hello, and thank you for having me. My name is Mardare, and I'm a general surgery resident working in an HPB team led by Dr. Ginghina and Dr. Iosifescu. A relatively young team, but a very dynamic and ambitious one. So I would like to talk today shortly about the life of the resident in such a team, a life that is a difficult one, but also a very, very satisfying one. So what does HPB surgery means? It's a surgery dedicated to the liver, pancreas, and the biliary tract, and covers a wide range of surgical interventions that vary from the so-called simple cholecystectomy, an intervention that can be done also by an HPB resident, going through pancreatic surgery, proximal distal pancreatectomy, and going to liver resections that can be small ones, partial, total removal, or the liver, or even a liver transplant. You should know that surgical residents interested in acquiring advanced training in HPB surgery should take up a fellowship in HPB surgery. Studies show that you should spend at least 4 years in an HPB center before specializing in this kind of surgery. So the specialty is here to stay, but the training is an evolution. So what does the real life of a resident in an HPB team looks like, and what does he have to do practically? First of all, he has to make sure that the patient gets safely to the operating theater and the surgery takes place in the best conditions. It resembles a lot like climbing a mountain with different obstacles on the way up. The pre and post-op management of the patient is let's call it the core function of a junior doctor. So it all starts with a thorough anamnesis and clinical examination. Even in this era of the COVID, we take our safety measures and perform a clinical examination of all our patients. And we have to keep in mind that careful analysis of paraclinic investigations and imagistic explorations are the key to the very best treatment to our patient. Preoperative imaging, so imagistic assessment of the patient plays, let's call it, a crucial role in developing a surgical plan, because we can establish the correct surgical indication, and it helps us to prevent complications. We need the help here of our colleagues, of our radiology specialists, and we often go there before planning on this kind of surgery. Sorry. So HPB surgery means a multidisciplinary team. That involves all kinds of specialists: radiology specialists, like I've said before, oncology, cardiology specialists, and anesthesiology specialists, and so on. That's why the pre-surgery evaluation is one of the most important steps in the treatment of these patients. We have to take in consideration all kinds of factors, such as cardiovascular or respiratory disease, chronic medication, conditions like anemia, and also the nutritional state of the patient before surgery. Dr. Ginghina mentioned before the carb loading before pancreatic surgery. It is well known that malnourished patients make poor surgical candidates. So we have to assess and correct and support the nutritional needs of these patients. So there are 3 key moments in this kind of surgery. establishing a relationship between the surgeon and the anesthesia and an anesthesia routine, training the team, and relying on checklists, and getting the help of our colleagues, our oncological specialist colleagues by establishing the tumor board. Anesthesia is a very, very important, plays a very important role in this journey, and it's very, very important to have a bridge between them and the surgeon. Little things like a low CVP during hepatic surgery may mean the key to a successful operation, like Dr. Ginghina mentioned before. HPB surgery is a complex one. Usually it's a complex, complex surgery, means long-lasting surgery, long hours, multiple operative steps, difficult dissections, difficult reconstructions, specific instruments and equipment. It is like he said before, for example, liver surgery is not only an abdominal surgery, or it's also a vascular surgery. So before starting the surgery, a resident has to make sure that the imaging investigations are exposed, and he has to go through checklists. Checklist makes our life easier, and can prevent mistakes. What to expect in an HPV surgery? Like I've said, long-lasting surgery, lesions that may not correspond on scannings or do not correspond to description before that we had pre-op, and we can have sad surprises like an inoperable lesion. So, or even an anatomical variant. Whenever possible, an anatomical variant should be identified pre-op. What do we do when we have such bad surprises? We often take a break, especially if the surgery is long, and we brace ourselves and start over with a new point of view. That picture is taken during an duodenopancreatectomy intervention. So the work of a resident doctor continues even after the surgery. Wound cleaning, bandaging, checking the urinary cancer, patient mobilization for faster recovery, and checking the intra-abdominal drain fluid are important aspects in ensuring the recovery of a patient that underwent such complex surgery. Complications. Being a complex surgery, HPV surgery has a high morbidity rate, which is why post-op we have to have we face a series of complications. Among the most common, we recall bleeding and biliary leakage, and every HPV surgeon nightmare, the pancreatic leakage. Well, as doctors, our attention for patients doesn't stop when we discharge the patient. So it is important that aspects like wound cleaning, suture removal, clinical and paraclinical reevaluation or diet, physical activity. We have to take care of these aspects too, and even take care of the complication that might happen after discharge. The readmission or the treatment, the antibiotic, anticoagulants that that the patient might need at home. This is the learning curve of a high volume center, and this is the learning curve in our medium volume center. But I would like to highlight that although there are differences between the two of them, we grow every year, and we've learned a lot since we have started this journey in 2013. As residents, mentorship is a key factor in promoting and maintaining fulfillment in surgical practice. So in our young team, we have, I would like to say, a bidirectional growth, both residents and both our mentors. How did they did it? In my opinion, we have to remember that working hard, studying and training every day, it's crucial to have, in order to have a career as an HPB surgeon. And we have to have in mind the words of Professor Buchler that said, resect, resect, resect. Or in other words, try to be surgically active every day. Last but not least, I would like to present to you our team. And to thank our mentors for all the support provided during the residency. And here are them, Dr. Ginghina and Dr. Iosifescu as residents too, and Dr. Zamfir. Thank you.
Thank you, doctor, for the presentation. Now we got some questions for you from our participants. What is the role of preoperative carbohydrate loading, and why carbohydrate sources specifically?
As Dr. Ginghina said, we recommend carbohydrating loading before complex surgeries, such as pancreatic surgery, because surgery, this kind of surgery is a very, very complex one, one that puts the body through a lot of stress. So we have to prevent the body not having enough resources to be able to resist to such a surgery and not to recover well after.
Okay, thank you. Another question. How many HPB centers are there in Romania?
Well, I think there are HPB centers in every big city that has an university. Cluj, Iași, Bucharest. But Dr. Ginghina?
It's always tricky to mention them because you're always afraid you will forget someone, and then
yes,
the next day the one will call you and it says you remind the Cluj and you said about Timișoara, and you remind Oradea and you didn't say about Constanța. So it's very difficult. There are HPB centers and they are growing. That's the most important thing. A little bit more mention about carb loading. It comes from sports. Huh? The carb loading concept comes from sports. It was brought to surgery, and it's true that there is a depletion of glycogen in any surgery. So the carb loading will help, especially because you have very difficult post-operative nutrition in the first days. We all know that parenteral nutrition will not be as effective as enteral nutrition, and of course in pancreatic surgery itself. And that is why we do this carb loading that is proved, and we follow European standard and European way to carb load our patients with orange juice or with apple juice. Sorry,
Apple juice. Apple juice. Yes.
Yeah, it's terrible.
Always apple juice.
It's terrible.
And I think this is the last one. How can we how can we steep the learning curve in minimal invasive HPB surgery?
How can you make it faster? How can you?
Yes.
You
yes.
don't. You don't.
Yes.
No, just stay in this hospital. Stay in hospital as much as you can. Stay 10 years in the hospital. Just stay in the hospital. You have seen Professor Clavien's slide with 10,000 hours. There's a 10,000 hour rules to become an expert. So if you want to be an expert, then stay in the hospital. Stay 10 years in the hospital, and you can then afterwards you can do the surgery that you love. There's no other way. But the problem is how long you stay in the hospital. That's the problem. And that's why HPB surgery doesn't get so much people as other surgeries, because you stay in the hospital for 10 years, but you stay till 4 o'clock or you stay till 8 o'clock. That's the difference. So our presentation today and our both presentations is just an encouragement for you to come and join HPB programs, because as you've seen before, there's a lot of fun in it. There's a lot of things that happen. People get bonded together because of the difficult cases that they manage. And that's why it's an encouragement for you to come and join the HPB research and HPB surgery programs. And of course, as you have seen in some of the photos, it's not easy, but it's not that difficult. It's just something that you get to learn. Don't try to go over the steps. And why am I saying this? Because we all have tried to go over the steps, and we've made mistakes, and we've learned from the hard way. So that's why I'm saying you don't. Okay, thank you.
Okay, thank you, doctors, for this amazing session, and I hope you enjoyed it, everyone.
Thank you very much for inviting us here. It was a pleasure.
Thank you.
We thank you for coming today and for this amazing presentation.
Okay.
Thank you.
Thank you. Bye.
Bye.